I wanted to dive into part of what you talked about with having a hospital that you contract with focus on one condition, because one of the next questions I wanted to ask was, who needs to be at the table as you design these bundles? And it sounds like you've got a part of your strategy to try to focus. This is the focus factory idea we read about in the literature, or centers of excellence, that all of the, I'll make something up, hip and knee will take place at this hospital, and maybe all the bypass grafts at this hospital. So can you talk a little bit about, as you built a model, be it the bundle or whichever, who needs to be at the table to build a really solid model? And then also this issue about focusing certain care in certain provider locations.
In the hospital landscape, you have different kind of hospitals. You have academic, you have high specialty, you have more common hospitals, and you have private clinics. And they all have a completely different cost structure and business model. And if you want to create value from a societal perspective, you need to have an idea which kind of patient should be treated in which hospital. If you have the most complex patients, you want them in the academic hospital. If you have a normal hip replacement without any technical issues, if you would do it in an academic hospital, you would pay too much. So there is a long tradition of making agreements between hospitals who is responsible, which level of complexity. So, because you can't manage them all in one bundle, that's why case mix adjustment is so complex. If you want to manage the full complexity of the range of complexity with case mix adjustment, it's very difficult. So it starts with defining who takes which kind of severity of patients. The second one is, if you say bundles are for stimulating innovation, for stimulating quality, you need to have some centers of excellence to do that. You're not going to do a bundle contract with a provider that only has very limited number of patients on that. So by making those statements, we try to set the market in movement to that hospitals, and especially doctors, they know they want to do the procedures. And if they know Silver Cross is not giving a contract for this procedure in my hospital, but they're going to give it to the other one, they're going to call and discuss, listen, if I do the procedures over you, with you, those doctors groups are more and more flexible between hospitals. They know they can concentrate and learn. And it's constantly looking for the balance between competition on quality and price, but also make sort of sensible view on the landscape of hospital care, who does what. Once you start defining a bundle, and we've done now I think 8 or 9 of those projects, and we're learning faster and faster how to do it, you do it with doctors on the table. You need the doctors, you need the finance group from the hospital, you need people with knowledge of claims and finance from our side. And what you do is identifying characteristic and look at all the costs involved. So which HIV, the identifying characteristic is people with a lab test that defines they have HIV. So you can define those people in our claims database, pick them out with a stick, and then look at all the costs those people make in average in a year. And then we go in depth with doctors. What's clinical relevant and what is not clinical relevant? What should we include in the bundle or not? And the reason why we do it is that you find all kinds of declarations of care we didn't know that was HIV related. Typical story is that when we did the HIV bundle, we noticed that this group also has a lot of dental care. There is no technical relation between HIV and quality of your teeth. It was a coincidence. But if you would do it on a sort of only financial perspective, you would have included it. But there is no, an HIV doctor is not able to influence dental care. So you really sort the pile of costs out until you have one that follows the patient journey, and then you start discussing what are avoidable costs, what are costs you can lower, where do you need more innovation, where you can do it. So it's something you mainly do with doctors.
So you pulled mostly the clinical representatives into the room, had the
Yeah.
discussion about what's the clinical path, where can you, use kind of a machine analogy, adjust the knobs
Yes.
to try to improve avoidable utilization, right? Increase
that's one part.
important
Yeah.
utilization. Okay. What about the business managers or chief operating officers at these organizations? Did they come into the question as well? Because they have a lot of influence over how their organizations operate.
It's a project you do in a number of steps. It first starts on a C-level, whether you do it or not, and what are the general terms. And one issue always is if you work with payment model where you pay a fixed amount of euros for a patient journey on average. One of the questions is how do you index that payment for national trends? Let's say wages are going up. Do you compensate for that? Another issue is medication. If medication falls out of patent and you get more generic medication, well, the bundle price should go down. Well, you start at C-level with this sort of rules of engagement. How do you interact with this price? If you wouldn't correct for wages, you know the hospital will lose money. But if you wouldn't correct for lowering medicine costs, we pay too much. So we start at C-level on those general terms. How does the contract work? And sometimes we don't agree and we fail and we stop because people say we feel it's too uncertain. The projects we did with GPs, we tried to expand them to other regions, and we had a number of GPs. They say we found it too risky to do it. We want certainty in a fee-for-service model. We're not going to do it. So that's once you reach that agreement, then you engage the clinicians and the doctors and the medical staff to look in depth. You need both levels in that order. If you don't do it in that order, it doesn't work. And now we are on the level that we have a number of those bundles who are solid. We have a lot of experience with data analysis. We have a lot of experience with how do you define and measure quality. And I think next year, maybe a year after that, our primary care bundles will be available to all GPs in the Netherlands. They can opt in.
Opt in for all patients or individuals?
No.
All or nothing?
All or nothing, because it is a population bundle. I think the situation that you can opt in at patient level, we will never do that, because we know from all kind of incentives we had in the past, it creates extreme perverse incentives. We will never do that. And I know in the US that's an option. You can opt in at patient level in some circumstances. From a Dutch perspective, we don't understand why you even propose such an option.
I want to take a little while and talk about the focusing on the individual hospitals with certain patient populations. And I'm trying to imagine, again, in my own market, hyper-competitive hospitals. And the idea that one of the major payers would come and say, oh, I'm sorry, we're only giving all of our hip and knee to this hospital. The rest of you are just out of luck. I can't imagine that scenario ever being acceptable. Can you talk me through a little bit about how that concept is playing out? How are there are about 6 hospitals in the Amsterdam area, as I understand. So that example, if you're saying we'll give all our hip and knees to one, how is that acceptable to the others? And is this a peculiarity of the Dutch system that won't apply to anyone else?
No. That's good that you put it back on the table. Well, we're not able to do that. The legislation will forbid us. On the other side, we contract hospitals, but in Dutch legislation, you can also, if a provider works out of network, we have to reimburse about 70% of the traditional fee. So there is always a backdoor for providers. And we see especially new private clinics coming into the market using this backdoor. They are out of network, but they do it for 75%. So we're not able to unilaterally say you get this procedure and the other one gets the other procedure. But there is a big but. Staff shortage is a huge problem, especially in Amsterdam. And especially specialized staff. For specific procedures, you need specialized staff. So you see, because of that, hospitals are already thinking about, if the staff is the limiting factor to growth, how are you going to organize it and how are you going to do it? So it's not that we can compulsorily say you get this and you get that. We know that they're already discussing it, and what we are doing is organizing those discussions. So what we say to hospitals, listen, if you move your cardiac patients from the academic to a more rural group, we give you that and that group back from another one. It's like playing cards. And in a very competitive market, all hospitals keep their cards to their chest. But what we do, that's our role as an insurance company, is saying, listen, you all have the same problems. Nobody wants to show their cards, so let us create some scenarios and see what happens. And because we know which patient groups and volumes are at different hospitals, we try to organize these meetings and sort of stimulate doctors to set those steps. But you have to create financial certainty on them. If you would say, listen, we are going to give all the hip knee to another, well, everybody would be incensed and we would forget it. But if we say, listen, we take a period for 3 years transferring this patient group from hospital A to hospital B, there are 2 doctors who are near retirement, we pay them off, so there is no issue. It takes a lot of time, a lot of talking, but the point is that if you use bundles to sub-optimize quality in a hospital, well, the other way around. You first have to optimize the volume of patient in a hospital, and then you set the next step.
I think that explanation helps a lot, and it feels more familiar, like, in a way, because we've done selective contracting in HMOs and PPOs forever.
Yes.
So I get what you're saying there. Very, very interesting approach.